Nice. Welcome to the latest episode of the General CCFP 105 Topics podcast. Today, we're tackling the very exciting topic of meningitis. I am still Caleb Dusdahl, but today I'm joined by the writer, researcher, and author of this episode, the newest northern resident to join the podcast, Andrea Brabant, a rural FM PGY1 out of the Northwest Territories. They're crushing it for us.
Hey, Caleb. I'm happy to be here. I just want to do a quick special shout out to Dr. Kate Breen, one of our superstar merge docs here in the NWT, who kindly reviewed this episode for us.
Thank you, Dr. Breen. We're going to jump into it. It's meningitis.
As a quick reminder, meningitis is defined as inflammation of the meninges, those membranes that are covering the brain and spinal cord. It's commonly due to infection, either bacterial or viral. This can happen through hematogenous spread, which is when, bacteria invade the bloodstream, often coming from the upper airway, and gradually make their way to the subarachnoid space.
Why would I just take a bite of peanut butter toast before it switched? But it can also happen through direct contiguous spread. This is when the organisms gain entry into the CSF from adjacent infections. So if they've got like a sinusitis or a brain abscess or otitis media, and then it directly penetrates from traumatic injury as well, or from congenital defects or during neurosurgical procedures. So there's tons of ways you can get infections spreading into your CSF.
That's right, and sometimes it can even be accompanied by inflammation of the brain tissue itself. In that case, it's called meningoencephalitis. But for today, we're just going to focus on the meninges themselves. So let's get started. What do you want first, Caleb? The good or the not so good news?
I'm an optimist, man. Give me the good.
Right on. Well, the good news is that since the most common causative bugs of meningitis are strep pneumo and meningitis, H. influenzae, the incidence of meningitis has greatly declined since the initiation of vaccination programs.
Huzzah! All right, that's good. I'm happy.
Awesome.
I'm pleased. What now is the bad?
Well, the bad news is that despite modern medical therapy, meningitis remains associated with a high case fatality rate of anywhere between 10 and 30%, and that doesn't even include unfavorable neurological outcomes.
So let's talk about how we can identify this thing, and that'll bring us into the first objective. Objective 1. In the patient with a non-specific febrile illness, look for meningitis, especially in patients at higher risk.
When we think of meningitis, we often think of the classic meningitis triad.
Fever, nuclear rigidity, and altered mental status.
That's right. That being said, all three features of this triad are only seen in about 40% of patients. So although this triad is highly suggestive, it's pretty far from being sensitive. Almost all patients, and we're talking like 99% here, will have at least one of these features, but just one is pretty non-specific.
So in a study that Andrea looked back on, 696 patients with confirmed bacterial meningitis demonstrated that at least 2 of fever, headache, neck stiffness, or altered mental status were present in 95% of cases. I'll take that.
Other symptoms that can present can include nausea and or vomiting, focal neurologic deficits, septic arthritis, or palpable purpura.
That's all to say, if you've got an unexplained fever, always think of meningitis, especially if you've also got something like nuclear rigidity, altered mentation, headache, or nausea, vomiting. Your radar's got to be up.
That's right, and especially if you're working with a population that's at increased risk. So this can include immunocompromised individuals, so think diabetes, chronic steroid use, splenectomy.
Patients struggling with alcohol use disorder.
Recent neurosurgery or abdominal surgery.
Any indwelling neurological devices, of course, or even cochlear implants.
Maybe obvious one is head injury, so especially if you're suspecting something like a basal skull fracture.
And unvaccinated folks, so those who don't have vaccination against Haemophilus influenza, strep pneumoniae, or Neisseria meningitis. And of course, you're thinking of neonates too. They're too young for the vaccines, for example.
Here in the Northwest Territories, we're looking at infants that are below 2 months of age, so that's when they would get their vaccinations. Another thing to just be aware of are individuals that are living in crowded spaces, so think shelters, kids that go to daycare, college dorms.
College kids are gross, for sure. Let's say, based on that story, that we do suspect our patient that we're seeing has meningitis.
Sure.
So what about the physical exam findings that we all get taught in med school?
It's a good question. I think you're talking about the Koenig and the Brudzinski signs.
The mighty, ubiquitous, yeah, those are the ones.
That's right. So the Kernick sign, as a reminder, was described as resistance to full extension of the leg when the hip is flexed, whilst the Brudzinski sign was described as flexion of both hips and knees when the neck was passively flexed.
And so search the internet if you need pictures of that, because sometimes the words don't do it justice.
Totally. These were historically thought as signs of meningeal irritation.
Okay, and is that good? Useful? Do we like these?
Well, the short story of it all is that it might not even be worth Googling these images. There's very limited supporting evidence and very low sensitivity, and I mean less than 10% for these, so-called classic signs.
She did it. She did the finger quotes on an audio podcast. I'm not the only one. The point is, they kind of suck, but you probably have to know them for exam purposes.
That's right. You might also hear about the jolt accentuation sign. It was initially thought that a negative jolt accentuation in a non-sick appearing patient would be sufficient to rule out meningitis, but multiple studies with large cohorts demonstrated that there was a really large ranging specificity and sensitivity for this sign. So all in all, it has limited diagnostic value. It's not reliable to rule out meningitis.
I'm bummed by that. I'm sad about this news.
Yeah.
What do we do instead?
It's a good question, and I think that brings us to our next few objectives, Caleb.
Oh my God, I set up a segue. Objective 2, 3, and 4. When meningitis is suspected, ensure a timely lumbar puncture. In the differentiation between viral and bacterial meningitis, adjust the interpretation of the data in light of recent antibiotic use. And for suspected bacterial meningitis, initiate urgent empiric IV antibiotics. The
diagnosis of meningitis is typically based on cerebrospinal fluid results obtained by a timely lumbar puncture. The key word here, Caleb, is being timely. The CSF sample is then sent for gram stain and culture, cell count with differential, glucose, and protein.
And if your patient is immunocompromised, consider adding PCR for HSV, herpes simplex virus, or other viral pathogens, especially in neonates. The CSF analysis is going to confirm meningitis via the white cell elevation and can help distinguish bacterial versus viral meningitis.
Now, before we get to those differences, I want to press a super important take-home point here. When bacterial meningitis is considered, never withhold, I repeat, never withhold empiric antibiotics in order to collect the sample. Delaying antibiotic therapy until the LP is completed is the most common error in the acute management of meningitis.
That being said, sterilization of CSF is possible within 2 hours. This highlights the importance of a timely LP. So even if you're going to be in a sleepy town somewhere covering the emerge once in a while, you should get your opportunities to get LPs done so you feel comfortable with them. I should repeat, they should not be delayed if your LP cannot be obtained in a timely manner. So get them started before you ship them to somebody who can get the CSF.
Early antimicrobial therapy is associated with a mortality benefit and reduced incidence of unfavorable outcomes. Currently in North America, the adult guidelines recommend starting a third-generation cephalosporin, commonly something like ceftriaxone, 2 grams IV, with vancomycin. We're looking at about 15 milligrams per kilo IV, with the addition of ampicillin, 2 grams IV, for listeria coverage. This is for patients that are over 50 years old, who are immunocompromised, or who struggle with alcohol use disorders. So again, looking at our high-risk populations here. You can also consider adding acyclovir if HSV encephalitis is also suspected.
All the antibiotics.
That's right. Throw the kitchen sink.
A 2015 Cochrane review demonstrated lower incidence of short-term neurological sequelae with the addition of dexamethasone, 10 milligrams IV, given before or with the first dose of antibiotics. The mortality in patients was reduced for those who had strep pneumoniae, and it also improved hearing loss as a sequelae in children with H. influenzae.
If not given before or with the first dose of antibiotics, though, forget about the steroids, as there's concern that it may reduce the antibiotic penetration into the CSF and cause further harm.
Okay, antibiotics, then timely LP if that has to be the order of operations.
Exactly. That being said, as long as there's no contraindications to an LP. So for example, you would want to withhold the LP if there's evidence of coagulopathy until it's corrected due to the high risk of bleeding complications like an epidural hematoma.
All right. Do we need to get a head CT before we do our timely LP?
Good question. Well, we've historically been preoccupied with identifying which patient is with suspected meningitis may have an intracranial mass, which would put them at harm of a post-lumbar puncture herniation. This was largely driven by several case reports finding a temporal link between LPs and herniation.
And so the concern with over-reliance on CT is that these patients aren't going to get the antibiotics prior to their CT scan. This practice has been associated with delays in getting the therapy that we need into the patient and also with associated increases in mortality. So what do we do?
So again, ensure you've got antibiotics on board first, then order a head CT prior to LP in patients with high-risk criteria. These include
altered mental status or deteriorating level of consciousness,
focal neurological deficit,
new seizures,
papilledema.
Yeah, you can see that.
I was thinking the same thing.
Immunocompromised state.
Malignancy.
A history of focal CNS disease like previous strokes, focal infections, tumors.
Concern for a CNS mass.
And this is a subheading, so a history of focal CNS disease and age over 60. So a reminder, that list that we just went through is the high-risk criteria that would indicate you need to get a head CT before you do the LP. Am I right?
That's right. After you've started antibiotics, of course.
Nailed it.
So we've got antibiotics on board, potentially a CT with an LP within 2 hours or less of giving empiric antibiotics.
Awesome. You did it. First poke, champagne, and you've got your CSF analysis results. You can confirm your diagnosis, right? Easy peasy.
Totally. With all that info, you can help see. Generally put, a bacterial meningitis will have an elevated opening pressure.
So use your manometer. A very high white cell count, over 1,000 cells per millimeter cubed.
With a neutrophilic predominance, usually over 80%.
Reduced glucose. We always learn that it's because the bacteria is eating up the glucose. Apparently that isn't true, but nonetheless, it's a useful brain tool.
Elevated protein.
And a positive gram stain. If you've got a gram stain, you've got bacteria in the CSF.
In comparison, in a viral meningitis, which tends to be more benign, and just by the way, treatment tends to be more supportive for these guys, your findings will include a normal opening pressure.
Learn to use your manometer. An elevated white cell count, but it's not going to be as impressive as the bacterial infection white count. Usually it's below 300.
And this time you'll have a lymphocytic predominance.
The glucose is probably going to be normal because I guess they don't eat sugar.
So will the protein.
And your gram stain is going to be negative because we don't stain viruses.
It is important to note that you may have to adjust the interpretation of the CSF data in light of recent antibiotic use. Despite a negative CSF culture, stopping antibiotics is generally not recommended in these patients if they are suspected of having bacterial meningitis. So if your clinical or other lab findings are making you think this is still potentially meningitis, do not stop the antibiotics. Review the other CSF parameters, so glucose, protein, white blood cell count, or request a CSF PCR analysis for viruses if it hasn't been done yet, because as we know, that can also cause meningitis.
Yeah, and then if your PCR from your CSF is positive for a viral etiology, you're probably okay to discontinue the antibiotics.
This is also a good time to assess alternative diagnoses, and remember that meningitis can also be caused by fungal infections or neoplastic processes, which would require specific CSF analysis. You can also consider TB meningitis, scary thing, in patients with a history of pulmonary TB or who live in areas with high prevalence. So that's a bit of a reality for us here in the north. All these analyses would likely be guided by your helpful specialist if needed.
Now, the results, these are going to take some time. You're not going to get them in an hour kind of thing. By the time they're processed, the patient is usually already admitted.
And since bacterial meningitis is spread by droplets, they're typically admitted on contact precautions, which is important to mention and brings us to our final objective.
Objective 5. Contact public health to ensure appropriate prophylaxis for family, friends, and other contacts of each person with meningitis.
The risk of developing bacterial meningitis post-exposure is actually estimated to be about 500 to 800 times higher than the general population. Luckily, with chemoprophylaxis, it's been shown to decrease transmission of meningitis by 89% in close contacts.
This is so easy to forget. Think about the contacts leading up to this. Chemoprophylaxis is recommended for individuals who have been in close contact with patients who have been diagnosed with Neisseria meningitidis and H. influenza meningitis. It is not recommended for patients diagnosed with pneumococcal meningitis. And these close contacts include things like housemates, individuals exposed to secretion, so if they've shared utensils, toothbrushes, kissed, and individuals who intubated the patient without a face mask. Never.
To be effective, chemoprophylaxis should be initiated within 24 hours of contact. Risk of infection after a period of 2 weeks from exposure is considered rare, and prophylaxis is not recommended after this time period.
So you've identified that there are some contacts who are at high risk. How do you treat them? With rifampin, 10 milligrams per kilogram IV, up to 600 milligrams per dose, and you do that Q12 hours for 4 doses. Your other option is ciprofloxacin, 500 milligrams orally, which is nice, once, or ceftriaxone 250 milligrams IM once. I think I know which of these I would choose. And it would be prudent to contact your local public health agency to ensure that they've gotten the appropriate treatment.
And obviously it goes without saying, important to advise these contacts to seek immediate medical attention if they develop any symptoms or signs of illness or meningitis.
Oh my God, is that it? We've done it?
That's it.
You did it. Amazing.
That's meningitis. Shall we do a quick review?
I am all about the spaced repetition. Let's do it.
Yeah, me too. I love it. All right. Our main take-home messages today are...
1. Meningitis is defined as inflammation of the meninges, most commonly caused by infection.
2. If you've got an unexplained fever, always consider meningitis, especially if it's accompanied by nuchal rigidity, altered level of consciousness, headache, or nausea and vomiting.
And especially if they're increased risk. Think of immunocompromised, heavy alcohol use, recent neurosurgery, head trauma.
3. To our great sadness, the Kernig and Brudzinski signs, as well as jolt accentuation sign, are generally unhelpful signs, other than maybe in your exams.
4. The diagnosis of meningitis is based on CSF results showing elevated white cells obtained by timely lumbar puncture. That was in bold. That means within a couple hours of antibiotic administration. Always give the antibiotics first and consider a head CT prior to LP in those with risk of brain masses.
5. For suspected bacterial meningitis, initiate urgent empiric IV antibiotic therapy prior to investigation. Delaying antibiotic therapy until the LP is completed is the most common error in acute management of meningitis. Don't do it. Start the antibiotics. As a reminder, IV ceftriaxone and vancomycin are a good place to start, with consideration of adding ampicillin for those at risk of listeria. You want to give dexamethasone before or with the first dose of antibiotics, otherwise not at all.
6. To differentiate bacterial versus viral, look at your CSF results. Bacterial has a higher white cell count with neutrophilic predominance and a positive gram stain, decreased glucose and increased protein, while viral, less impressive elevated white cell count with lymphocytic predominance, a negative gram stain, and normal glucose and protein. 7. Finally, ensure appropriate chemoprophylaxis for close contacts for patients diagnosed with Neisseria meningitis and H-flu, ideally within 24 hours of that contact, and then check in with your public health agency for help or to tell them you fixed it.
And that's it for meningitis.
Yay! It says what a headache, but I had a great time. Come help us. We need people who want to do episode art, who want to do nice short show notes, and we always need people for episode art. We got some stuff coming out this spring too, which will be a lot of fun. So keep in touch. Thanks, Andrea.
Right on. Thanks, Caleb.
Thanks, Dr. Breen. Bye-bye.
See you later.